Dr. Raj is head of the stroke unit and is a senior consultant neuro-interventionist at the ARTEMIS Institute. He is going to speak about another important topic in the stroke management, vessel wall imaging.
Good morning all, and I thank the Academy for inviting me today to talk about vessel wall MRI. So, being a stroke neurologist and interventionist, I feel it's a very important topic because we see a lot of young patients with intracranial stenosis, and many times we find it very hard to identify the underlying etiology for the problem. So, let's look at this particular patient here. What do you think is the etiology? If you see here, there is a tight stenosis in the M1 middle cerebral artery. He's a 39-year-old male. If you see here, there is stenosis involving bilateral origin of the renal arteries, and there's also left subclavian stenosis. And this was a patient who was referred from a peripheral hospital. Luckily, he had a vessel wall imaging done there as well. And if you see here, this is the middle cerebral artery here. This is the T1 post-contrast imaging. There is some enhancement of the wall of the artery, and the enhancement is nearly 2/3 of the wall of the artery. And the physician had started steroids based on the report saying that it is vasculitis. But the question is it vasculitis? And that's the question that we are going to answer through this particular talk. So, vessel wall MRI, so the objectives of the talk is we will talk a little bit about vasovasorum, the technical aspects of how to do the imaging, and how do you match the imaging with the pathology and the pitfalls of the imaging. So there are two types of arteries here. One is artery X and the other is artery Y. In artery X, if you see, there is a well-developed internal elastic lamina, whereas in artery Y, you don't see the internal elastic lamina. Whereas in artery X, there is no external elastic lamina, whereas artery Y has a well-developed multiple layered of external elastic lamina. And if you see here in artery X, there is no vasovasorum in the adventitia, whereas artery Y has vasovasorum. So the artery X is an intracranial artery, which is devoid of external elastic lamina, and it is devoid of the vasovasorum. So why are we talking about the vasovasorum? I think it plays an important role in the arterial wall pathologies. It's generally not present in the intracranial circulation. It develops with age, and if at all you see the vasovasorum in the intracranial circulation, it will be the proximal arteries. It has artery, capillary, and vein, and plays a nutritive role. And it is usually seen when the muscular layers are more than 29. So if there is a medial thickness is more than 350 micron, then that is when you see the vasovasorum to give the nutritive supply to the arterial wall. So there are two types of vasovasora. One is vasovasora interna, which is self-explanatory. It comes from the artery itself. And the other one is vasovasora externa, which comes from the side branch, and it supplies the arterial wall. So the technical aspects of how we do the vessel wall. So the normal thickness of the wall is very small. It is 0.2 to 0.3 mm. So we have to generate a signal from the wall, but suppress all of the signals from within the wall of the artery, as well as outside the wall of the artery. We know in a disease state, the wall will thicken, and therefore we will be able to generate a signal from the wall of the artery. And we want to use a 3 Tesla MRI, so we have a higher signal-to-noise ratio. So the important points, suppression of signal from the blood, that is a blood-black sequence, as well as from the surrounding neighboring tissue. We image in multiple planes, and we have multiple tissue weightings. So we have a T1 coronal axial sagittal section. So you do a T1 post-contrast, as well as a T2 imaging. So why do we want to do it? So we'll be able to differentiate different diseases of the intracranial arterial wall. To be able to see the not so obvious, can we assess disease activity, and where can we assess response to treatment? So how useful is this imaging? And this is an interesting paper in stroke, which showed that the correct diagnosis rates increased from 36% to nearly 88%, and the inter-rater agreement significantly improved from 0.02 to 0.72. So therefore, I feel it plays a significant role in identifying the underlying pathology. So what are the different states that we are going to discuss? One is Moya-Moya disease, vasculitis, RCVS, and atherosclerosis. What happens in Moya-Moya disease? The intima thickens, and what happens is what we call as negative remodeling. The entire artery shrinks down, and there is the media is atrophied. The intima thickens, the media atrophies, but the thickness of the wall remains same. When you look at vasculitis, there is thickening of the wall, there is the lumen narrows down, and there is transmural inflammation, and the internal elastic lamina breaks down. In RCVS, the lumen narrows down, The main feature here is the media thickens. The actin and myosin filaments overlap. There is a 5-fold increase in the medial thickness. And there is no inflammation in RCVS. In atherosclerosis, the lumen is variable, the thickening is eccentric, and you will notice some inflammation in the plaque. So let's talk about intracranial atherosclerosis. What is the pathogenesis? What are the remodeling patterns? Where is the site of the plaque and the enhancement patterns? So in intracranial atherosclerosis, the first stage is wall thickening, and this results in formation of vasoviscera, which promotes atherosclerosis. It plays a role in initiation, progression, and intraplaque hemorrhage. There are two types of remodeling in the intracranial atherosclerosis. One is called as positive remodeling. The other one is called as negative remodeling. So many times we see patients with stroke, but the imaging looks normal. And that's because we have what is called as positive remodeling, and this helps reclassify the stroke into due to atherosclerosis. So what is positive remodeling? There are two important anatomical parameters you need to consider. One is the vessel area, that is the outer yellow line, which depicts the outer wall of the artery, and the green circle, which depicts the wall of the lumen, the outer lining of the lumen. So you have the vessel area and the lumen area, and the difference between the vessel area and the lumen area is the plaque size. So why is it important? What happens in positive remodeling? If you see here, this is the disease site. The vessel area at the lesion site is bigger than at the reference site. So this is a positively remodeled artery. So the ratio is more than 1. What you see here is the plaque burden is quite high, but the lumen remains normal. You wouldn't see there any narrowing in the lumen. So that is a positively remodeled plaque. Whereas in negatively remodeled plaque, what you see here is the vessel area, the outer wall of the artery itself is shrunk. The vessel area at the lesion site is smaller than the vessel area at the reference site, therefore the ratio being less than 1. You see the plaque burden is not that much high, and the lumen is reduced. Why is it important? It's very interesting to, there's a lot of work done in cardiac literature, and that we have transformed into neuro literature also. So what plaque burden actually causes narrowing? So initially what happens when there is an increase in plaque, the outer diameter of the artery starts increasing. Because if the outer diameter starts increasing, the lumen relatively is preserved at the early stages, but as the plaque burden keeps increasing, the lumen starts shrinking down. So this is the stage of how initially positively remodeled plaque and then becomes a negatively remodeled plaque. So in cardiac literature, up to 40% plaque burden, you will not notice any narrowing in the lumen of the artery. What is in intracranial? What happens in internal carotid artery? You need 65% plaque burden to actually see any narrowing within the artery. And one other important thing is, for the interventionist, we want to know what happens in the anterior circulation and posterior circulation. In the anterior circulation, what we see more commonly is a negatively remodeled artery. So for us, if there is ICAD and we want to do an angioplasty, we know the outer lumen of the artery itself is narrow, so we don't want to do an aggressive angioplasty in that subset of patients. Whereas in the posterior circulation, it's more a positively remodeled plaque. So let's look at a case. So this is a patient who has a M1 stenosis here. This is the vessel wall imaging. The green line represents the outer lumen of the outer diameter of the artery. If you see here, it is narrowed down. So we know it is a negatively remodeled artery. And you also see that there is a luminal compromise. This is a negatively remodeled intracranial atherosclerotic plaque. Compare that with the basilar plaque. I told you earlier on that posterior circulation is more positively remodeled. You see the lumen is maintained, but there's a good plaque burden here. And in the vessel wall imaging, you see the outer lining of the artery is still preserved. In fact, it has expanded, the artery over there. And if you see, the lumen is also relatively preserved. So this is a positively remodeled plaque. So why is it important for a clinician? Many times we see cryptogenic strokes. We say it is cryptogenic. But if you actually see these deep strokes, you can help reclassify these strokes as intracranial, due to intracranial atherosclerotic disease. And therefore, it is very important. And we know that positively remodeled plaque means more risk of stroke as compared to negatively remodeled plaque. And we also are able to see which wall of the artery this plaque is in. So if you see, this is a sagittal section T2 MRI, where we look at the middle cerebral artery. We can divide it into 4 quadrants based on 2 diagonals here, the superior, inferior, ventral, and dorsal. In this particular instance, you see the plaque in the anterior wall, the ventral wall of the middle cerebral artery. So we have a specific predilection to which wall this plaque involves. It commonly involves the anterior and inferior walls, but in patients who have had a stroke, it commonly involves the anterior wall and the superior wall. Why is that? We know the perforators come from the superior and the posterior wall of the middle cerebral artery, so a superior plaque. So, for example, if you have an ICAD, which is recurrently symptomatic, and as an interventionist, I want to know where the plaque is. So when I'm doing a balloon angioplasty and put a stent across, I want to know whether that perforator get occluded following the procedure or not. And therefore, it is very important nowadays to look for which wall the plaque is involved. Compare that for a basilar artery. In the basilar artery, again, you can divide it into 4 quadrants based on these 2 diagonals here. It generally involves the ventral wall, which is good for an interventionist because the perforators come from the lateral and the posterior wall. So I'd also mentioned the posterior circulation is more commonly positively remodeled. That's because they feel that there is low wall shear stress and there is lack of sympathetics in the posterior circulation. So one more thing, a very interesting point that I noted in coronary literature, they found that the plaque tends to occur in the wall opposite to the side branch takeoff. So this is the coronary artery dividing into left circumflex and left anterior descending. Generally, they found that the plaque occurs on the wall opposite, which is very good for us because we know the perforators come from the posterior superior wall, and if the plaque is in the anterior wall, we're more comfortable doing that balloon angioplasty and stenting. More information from intravascular ultrasound in the coronary literature. If you see here, if this is a side branch that is taking off, the plaque tends to form on the wall opposite to that takeoff. If there's an angle takeoff, what you notice is the plaque forms ipsilateral to the angle takeoff, and if there is a anti-clockwise angle takeoff, there is a plaque forming in the wall ipsilateral to the angle takeoff. So one other interesting factor, we have seen a lot of ICA origin stenosis and MCS stenosis, and they always almost follow a particular pattern. In this particular ICA stenosis, you see the plaque is forming in this wall. I never see plaque forming in the inner wall of the where this flow divider is. And even in the external carotid artery, I will see a plaque forming in this wall and never on the flow divider. And similarly, in the middle cerebral artery, if you see here, the plaque forms on the inferior wall and the anterior wall, and that's explained by the curvature of the artery. And that's what we will explain in this particular diagram. It looks too complicated, but I'll try to make it as simple as possible. This is the common carotid artery, which divides into internal carotid artery and the external carotid artery. And this is the flow divider that we discussed. So what happens to the flow from the common carotid artery? As it enters, the jet enters the internal carotid artery, there is what is called as a separation point. At this point, the flow does not gets separated off the wall of the internal carotid artery and does not abut the wall. So what you get is called as a dead space there. So the dead space has to be occupied from blood from somewhere else, and that blood is usually from the jet that hits the flow divider. So there are 2 phenomena that occurs here. So once this is a very high velocity jet, when it hits the flow divider, it takes a circumferential route, and then it enters this dead space here, and then there are 2 things that can happen. One, it can take the reverse direction and then turn around and join the mainstream, or it can take a helical pattern and sort of enter the mainstream. Why is it important? There is a stagnation point between these 2 jets here. So one jet coming like this and going into the mainstream, and one jet which takes a helical pattern. And at this stagnation point, what happens? The flow velocity is very low. Whenever the flow velocity is very low, the wall shear stress is very low. Whenever wall shear stress is very low, it promotes atherosclerosis. And we know that low wall shear stress means atherosclerosis. And so I talked about stress. There are 2 types of stress. One is the normal stress, which is perpendicular to the artery, and the other stress is which is the tangential stress, which is parallel to the wall of the artery. And we know that wall shear stress, if it is low, it is a high-risk plaque feature and a positive remodeled plaque. If it is a high wall shear stress, it inhibits TNF and interleukin beta. It is actually a stable plaque, and there is no progression in the plaque. So 2/3 of the strokes are due to low wall shear stress, positive remodeling, high-risk plaque feature, and plaque rupture. 1/3 of the strokes are due to high wall shear stress. How does it cause a stroke? It's not a bad plaque. It's a calcified fibrotic plaque. So what happens here? The endothelium gets sheared off, thrombus forms on the wall of the plaque, and that's what embolizes and causes the stroke. So now coming on to the vessel wall imaging itself, I wanted to give a brief about negative and positively remodeled plaques. And one of the take-home points I would say today is, whatever might be the stenosis, first try to rule out atherosclerosis. Atherosclerosis is still common at 20s and 30s. So rule out atherosclerosis before you can say it is vasculitis. So this is an axial T2 imaging, where we look at here, is this outer white line represents the outer diameter of the artery. This is the lumen of the vessel. And you see this T2 hyperintensity there. And that represents the plaque, fibrous cap of the plaque. And this hypointensity on T2 represents the fatty core. And as I mentioned here, fibrous cap is T2 bright. The lipid core, usually we see lipid as T1 and T2 bright, but here we see the T2 hypointense, and that's because it has cholesterol and cholesterol and not triglycerides. And this is a plaque where there's a fibrous cap rupture here, and there's exposure of the plaque contents into the vascular lumen. Another important thing is we also looked at T1 pre and post contrast, and what we see here is there is enhancement of this fibrous cap, and it can be a lumpy enhancement. And we also look at the T1 sequence to see if there is pre-contrast, to see if there is any T1 hyperintensity, and if there's a T1 hyperintensity, as here, if there's a tight M1 stenosis, there's a temporal lobe infarct on the T1, you see that T1 sequence, there is a pre-contrast hyperintensity which could represent an intraplaque hemorrhage, and that means this could be potentially an active plaque. What also we look for is the extent of enhancement in the plaque. If the extent of enhancement is similar to the pituitary stalk, it is a grade 2 enhancement, and the level of enhancement also correlates with the extent of it being symptomatic. So the type of remodeling I'd already discussed, again, is important for the interventionist to see which wall is involved, what type of remodeling it is, and we discussed also the imaging patterns. On a T2, we see the fibrous cap as bright, the lipid core as dark, and T1, we want to see pre, if there is a hyperintensity which suggests that it could be an intraplaque hemorrhage. Now, moving on to other conditions, we see vasculitis. There's usually a smooth concentric wall enhancement and thickening, and the enhancement is because of the increased permeability of the endothelium with contrast leakage from within the lumen into the arterial wall. Sometimes it could be vasoconstriction-related contrast leak as well. In this particular instance, you see basilar artery, there is stenosis, multiple smooth stenosis, even in the PCAs as well as the superior cerebral artery. If you see here, this is the T1 post-contrast. Clearly, there is circumferential thickening and wall enhancement of the basilar artery as well as the PCAs. So in vasculitis, what we see is it can be short segment unilateral or bilateral, single artery or multiple vessel. It generally can extend into the periadventitious tissue as well. And the enhancement lasts for a long period, 7 months, 9 months, 12 months. Even after treatment, it can persist. So that doesn't mean the disease is active. So are there any studies to say that can we actually monitor disease activity? There is paucity of studies right now. We can't really say. They have also done biopsies based on vessel wall MRI. They have done a whole brain vessel wall MRI and decided which side to look for and take a biopsy. And in that particular study, there was a very good yield. Whether this would translate into clinical practice, I don't know. Usually the biopsies based on MRI is not great. The yield is low. And therefore, this is something we may need to think about. So always there is a problem, right? So the first case I showed, there's nearly 2/3 thickening, 2/3 enhancement. Will it go into atherosclerosis or vasculitis? The nephrologist coming and saying bilateral renal arteries involved, subclavian involved. I'm thinking it is Takayasu. Rarely Takayasu can affect the middle cerebral artery. So there's one pearl here. So whenever you see the imaging, you also look at the T2 imaging. And on the T2 imaging, you look for this particular sign where is there any T2 hyperintensity that is juxtaluminal? If there is a T2 hyperintensity which is juxtaluminal, it will point to a fibrous cap, and therefore it is not vasculitis. Why? Vasculitis may not necessarily be concentric, and atherosclerosis rarely can have almost all circumferential wall involvement. Now, moving on to RCVS, I had mentioned here, it is medial wall thickening because the actin and myosin filaments overlap. There is 5-fold increase in the size of the thickness of the artery, diffuse involvement of the middle cerebral artery. Generally, there is no enhancement in RCVS, so that is easy to make out. So what are the differentiating features? We look at T2 hyperintensity. Usually in intracranial atherosclerotic disease, you will see it. In vasculitis and RCVS, it's absent. I discussed this. T1 wall thickness is eccentric in ICAT. Vasculitis, it's circumferential. RCVS is also circumferential. Contrast enhancement is in ICAT grade 1. It is less than the pituitary stalk. Commonly, vasculitis is grade 2 as much as the pituitary stalk. And diffuse pattern of enhancement in ICAT, heterogeneous or focal, but usually in vasculitis and RCVS, it's diffuse. Usually RCVS, we don't get it. Now, moving on to Moya-Moya disease, I'd already mentioned it's intimal hypertrophy, atrophic media. Because there is intimal hypertrophy and atrophic media, the wall thickness is usually maintained, but there is negative remodeling in Moya-Moya disease. An example case here, bilateral ICS, we don't see here. If you see here, there is the wall thickness is maintained. Post-contrast, you don't see any enhancement. Moving on to use of vessel wall MRI in aneurysms. We know that there may be some role of vasovasorum in aneurysms, particularly if there's a large aneurysm, more than 4 mm aneurysms or saccular aneurysms. So what we look for is circumferential arterial wall enhancement if there is of the aneurysmal wall. If there is a circumferential aneurysmal wall enhancement, and if it is grade 2 enhancement, then there is a 9-fold risk that that particular aneurysm is likely to rupture. Or if there are multiple aneurysms and you see this in this particular aneurysm, and you may have to consider that to be the symptomatic one. We know the wall thickness is 0.3 mm, but at the rupture site is 20 micrometer, is 0.02 millimeter. That's where we're putting the coils in. So if you see here, this is another paper which just suggests that a circumferential arterial wall, aneurysm, sorry, not an arterial wall, aneurysm wall enhancement points to a chance that that particular aneurysm is going to be unstable or probably the ruptured one. Diffuse subarachnoid hemorrhage, you see a right PCOM aneurysm, left PCOM aneurysm, and you want to decide which one is ruptured. If you see here, there is enhancement in the left PCOM and nothing in the right PCOM. And we know this is probably the ruptured side. Post-recanalization also, we do see some circumferential enhancement, and that is because of endothelial denudation and endothelial permeability. Some pitfalls, when there is slow flow, you would see that there is wall thickening, but on contrast imaging, it is not there. And sometimes venous contamination, there can be some venous enhancement along with the wall, and that can be considered as enhancement. So going through some cases. So now that we have discussed 5 etiologies, we'll just have some examples. This is a patient who had Fabry's disease, had cataract skin disease with right hemispheric stroke. This is the first event, some anomalous arch, right hemispheric infarcts you see. There is some narrowing in the terminal ICA. Another important point, whenever the terminal ICA and M1 both are involved, you may have to think about Moya-Moya as a possible etiology. M1 alone, then I think more, atherosclerosis is possible etiology. So here, if you see the terminal ICA is involved, I want to rule out other possible etiologies in this particular instance. We did this, we did a vessel wall imaging. If you see there is near concentric enhancement, there is thickening. A1 origin is also involved on post-contrast imaging. 2 weeks later, second event, 10 weeks later, we did a lumbar puncture, we did extensive screening. There is some borderline ratio for varicella VZV. Again, you see very thick concentric enhancement, very grade 2 enhancement here. And there is increase in the narrowing. And third event, again, after a few days on antiplatelets, and the artery is further narrowed down. So in this particular instance, we think it is vasculitis only. I don't think it is atherosclerosis with this rapid progression over weeks. And this patient eventually, and please do not do angioplasty and stenting. This is an absolute no-no, and this artery will rupture. So this patient went for a bypass surgery. So this is a 37-year-old doctor with right-sided symptoms. If you see, there is a tight stenosis involving the left middle cerebral artery, and MR angiography. This is the DSA picture here. If you see here on T1 post-contrast imaging, you clearly see the fibrous cap enhancing, and it's eccentric wall thickened and enhancing eccentrically, grade 2 enhancement. This points to an atherosclerotic disease. Another patient with left hemispheric stroke, there is involvement of the terminal ICA, A1 origin, and the middle cerebral artery. And if you see this circumferential wall thickening, grade 2 enhancement, in this particular instance, we thought it was vasculitis. She was treated on immunomodulators, and you see this after 9 months, it is still persisting. That doesn't mean the patient has been asymptomatic. That doesn't mean the disease is still active. One other important feature which I'd already mentioned to you earlier on is to look for this fibrous cap. As long as you look for this fibrous cap here, which is juxtaluminal, I'm sorry the images are not good, then that would point to an atherosclerotic etiology. So last few slides for me here. Now, coming on to this 39-year-old male with hemispheric stroke and this M1 stenosis, if you see the ICA is not involved, both renal arteries are involved, subclavian is involved. There is a question this can be Takayasu arteries to and fro, but the important thing was missed here. See, again, as I said, vasculitis can be 2/3 involving. It may not be circumferential. And if you see the T2 imaging, what do we see here? It's beautiful fibrous cap seen there, juxtaluminal, and therefore it is an atherosclerotic lesion, and therefore and if you see the CT angiography, there's extensive calcification infrarenal, nothing involving the aortic arch at all. So we know this is atherosclerotic disease. We went ahead and stented this patient. So the last slide, and this is the take-home message, we talked about negative remodeling, meaning the outer diameter of the artery itself shrinks, and positive remodeling, the outer diameter of the artery increases. There's only one condition which positively remodels, that is intracranial atherosclerotic disease. The rest of them, what happens is the outer diameter is maintained. One other where there can be increase in diameters, dissections, which I had not actually discussed here. So the first condition, what do you think it is? So there is negative remodeling. I want answers from the audience here. There is negative remodeling. There is maybe some enhancement in the wall of the artery. Diagnosis? Sorry? Fantastic. Moya-Moya disease. There is the lumen is reduced, the wall is thickened, there is grade 2 enhancement, very avid enhancement, concentric pattern. Diagnosis? Fantastic. This one, tough one. So what is here? So if you see here on T1, there is increase in the diameter of the artery, it is eccentric, and there is some T1 hyperintensity. Fantastic, dissection. So this is potentially a dissected artery where there is expansion of the artery, there is asymmetric thickening of the wall, and this potentially could be dissection. And this one, atherosclerosis. Fantastic, thank you very much.
Thank you, Dr. Raj, for the excellent talk. I think